Hello, my name is Ahava Rosenberg, and I will be talking to you today about MRI of ankle tendons with emphasis of what's important. So the focus of discussion is going to be general comments. I'm going to talk about these tendons, the posterior tibial, peroneal, and Achilles, which are most commonly involved in the ankle. Then we're going to talk about the spectrum of disease of tendon pathology, which is tenosynovitis, tendinosis, rupture, and dislocation, keeping in mind that tendon pathology could be traumatic, could be degenerative, could be inflammatory, or even deposition. And my feeling is tendon is tendon is tendon. Pathology is similar all over the body. But what we need to pay attention to is associated findings or other things to look for once we identified the tendon disease. So this is an axial image on a cadaver, and these are the tendons that we're going to be mainly interested in: the Achilles tendon, the peroneals, the posterior tibial tendon. I'm not going to have time to cover the anterior tibial tendon. It's not a common pathology, but just keep it in mind to look for it. The rest of the extensor tendons are really rarely abnormal. So when we look at tendon disorders, I mentioned tenosynovitis. Tenosynovitis is inflammation of tendon sheath. We usually see fluid within the tendon sheath. If it's a stenosing tenosynovitis, you may see what looks like obliteration of the fat and scarring. This happens to all the tendons, excluding the Achilles tendon, because the Achilles tendon does not have a tendon sheath. It has paratenon, so the Achilles has paratenonitis rather than tenosynovitis. Keep in mind that fluid is very common in the flexor hallucis longus tendon sheath, and most of the time it's not tenosynovitis. We're going to look at tendinosis, which is intrasubstance degeneration that occurs in all tendons. Rupture of tendons usually occurs when there is underlying degeneration of the tendon. Nevertheless, you can present as a more acute event, such as Achilles tendon, or a more chronic progressive pathology, very common in the posterior and anterior tibial tendons. We're going to look at partial versus complete, and finally we're going to look at dislocation, and that's most common in the peroneals, less common in the posterior tibial tendon. There are actually reports of flexor hallucis longus dislocation as well. Before we start, let's talk about the magic angle effect. This is an old image, but I like it because it actually shows the magic angle effect in the posterior tibial, flexor digitorum, and flexor hallucis longus. And this is increased tendon signal, even if the tendon is normal, and it's associated when the structures have or form a 55-degree angle to the main magnetic vector. This is seen mainly in low TE, such as T1, sometimes proton densities, very common in posterior tibial tendon as it inserts into the navicular, in the peroneals, flexor hal, and the extensor tendons. So how do we distinguish that from pathology? True pathology, we look at the morphology of the tendon. Even if you don't see the tendon at the site of magic angle, you look at it above or below. You look and you correlate with high TE sequences. So if the tendon looks normal on T2 weighted images or stir, then it's probably a magic angle effect. We usually, most people by now, image our patients in neutral supine position, which is about 12 degrees to 20 degrees of plantar flexion. That pretty much avoids magic angle effect. There have been reports on imaging in prone. In my opinion, that's really not necessary. Keep in mind that you may have small amount of fluid within tendon sheath that is physiologic, that is not tenosynovitis, except when you see it in the extensor tendons. Extensor tendons all over the body usually should not have fluid, and if you do see fluid, it's pathologic. I told you that the flexor hallucis longus often will have fluid within the tendon sheath. This is because it communicates commonly with the ankle joint, and you can have decompression into the flexor hallucis longus tendon sheath. Notice it here. The fluid surrounds the tendon, but it's very clean fluid, right? Compare it, for example, to this one. This is a patient with psoriatic arthritis, and we see that the tendon fluid is dirty the tendon sheath is lobulated, and there are a lot of abnormalities in the bones. There is increased signal in the bone. This is a patient with psoriatic arthritis and true flexor hallucis longus tenosynovitis. Another thing is to keep in mind is that tendon sheath fluid may be associated with adjacent abnormalities of soft tissue structures. So, for example, the peroneal tendons are in close proximity to the calcaneofibular ligament. When you have tears of the calcaneofibular ligament, this can cause fluid to extend into the peroneal tendon sheath. Initially, you can have just fluid, but eventually this may develop into stenosing tenosynovitis because you often have hemorrhage associated with it. Similarly, when you have deltoid ligament injury, the posterior tibial tendon sits right by the deltoid, and you may have reactive fluid surrounding the posterior tibial tendon. When you see multiple tendon involvements, think about it could be ligamentous injury, it could be rheumatological disorder. In this particular patient, we have fluid surrounding the flexor digitorum, the flexor hallucis longus, and the peroneal tendons. This woman had a recent ligamentous injury, and we can confirm it by seeing a tear of the anterior tibiofibular ligament, right? It is discontinuous at this level. We also see edema here. That's a clue for syndesmotic ligamentous injury. This is a different patient. In this patient, this was a 24-year-old. We see PERONEUS brevis, longitudinal tearing, maybe even PERONEUS longus tearing. We see posterior tibial tendon tearing. We see tenosynovitis. What's a 24-year-old doing with so much abnormality? This is a patient with rheumatoid arthritis. So keep in mind, especially when you see multiple tendon involvements, and especially when you see young people, keep in mind the possibility of an inflammatory process. So this patient has edema in the distal tibia adjacent to the posterior tibial tendon. Sometimes you can have reactive marrow edema related to abnormalities of the tendon. Here we see partial rupture of the posterior tibial tendon. This can also happen commonly with the peroneal tendons, particularly the PERONEUS longus. Whenever we see edema along the plantar aspect of the cuboid, maybe edema in the lateral wall of the calcaneus, think about PERONEUS longus tendon abnormality and friction-related changes. We're going to move now to specific tendons. We're going to look at the posterior tibial tendon. The posterior tibial tendon is the most medial tendon. It's a very strong plantar flexor and inverter of the foot, and you could see why, because it has multiple tendon insertions into the midfoot and base of the forefoot. The posterior tibial tendon should be about 2 to 3 times as big as the flexor dig. If you see changes in that proportion, think about tendon pathology. Posterior tibial tendon dysfunction is usually a degenerative process. It also goes from tenosynovitis via tendinosis to rupture. Often these can coexist, by the way. So it predisposes or causes progressive acquired flat foot deformity, most commonly in middle-aged or elderly women, much less commonly in young adults. And the symptoms are usually pain and tenderness or swelling along the medial aspect, along the course of the posterior tibial tendon, but eventually they can have lateral pain, and I will go through why. Conservative treatment is usually early on, particularly when you have flexible flat foot deformity. Surgery is when the flat foot deformity is more advanced, more painful, and you're starting to have rigidity. When we look at the MRI, we should be distinguishing type 1 and type 2 partial ruptures from complete ruptures. Treatment could be very different. And again, we need to look for associated findings. So, for example, we need to look at the spring ligament. We need to look at the sinus tarsi, and we look at extra-articular impingement. So here we have 2 different patients. This has tenosynovitis within the posterior tibial tendon sheath, but the posterior tibial tendon itself is normal in size relative to the flexor digitorum longus tendon. Compare it to this patient where the posterior tibial tendon is markedly enlarged relative to the flexor ditch. It has increased signal in it, so it's more advanced partial rupture as well as surrounding tenosynovitis. This is a case where often this type of pathology of the posterior tibial tendon gets missed, and the reason for that is because the posterior tibial tendon demonstrates normal morphology and signal, but in actuality is too small relative to the flexor digitorum longus tendon. This is a markedly attenuated, elongated, dysfunctional tendon. This is a type 2 partial tear. And finally, and we don't see that commonly because these cases get picked up more early now, we see a complete posterior tibial tendon rupture. This is a type 3 complete rupture. Now, once we identified posterior tibial tendon disease, we need to look at other things. For example, the spring ligament. So the spring ligament holds the talus in place. It supports the medial aspect of the talar head, and it's located deep to the posterior tibial tendon. In this particular patient, 36-year-old with flat foot deformity, the spring ligament is a little bit thickened. This is the superior medial component. It goes from the sustentaculum to the navicular. Compare it to this patient with more advanced posterior tibial tendon rupture, and now we see that the superior medial component of the spring never reaches the navicular, and this is retracted and completely torn spring ligament. They will repair the spring ligament, so you need to know about it, and you need to tell them. The surgeons want to know that. So this is a normal superior medial component of spring. It also inserts into the tibiotalar component of the deltoid. Compare it to this patient with posterior tibial tendon dysfunction, marked tearing, marked flat foot deformity. The tibiotalar component of the deltoid is markedly thickened, and the superior medial component of the spring is actually gone. We also see thickening of the plantar component of the spring ligament. We also see marrow edema in the talar head medially, and that we see every once in a while because of friction related to the pronation and rotation, medial rotation of the talus. Now, another thing we need to look for is extra-articular lateral impingement. So normally there is fat between the talus and the calcaneus with failure of the soft tissue structures, the PTT and the spring that support the longitudinal arch. We get encroachment between the talus and the calcaneus, and we can get sinus tarsi syndrome here or tibiocalcaneal impingement. And finally, we're going to get calcaneofibular impingement. As we see here, this patient is very flat-footed, but she's going to have pain laterally because of that extra-articular lateral impingement. So here we have a patient with PTT dysfunction. We see complete obliteration of the fat within the sinus tarsi with fluid here, consistent with sinus tarsi syndrome in the appropriate clinical setting. But we also see edema at the opposing talar and calcaneal surfaces right here in this area, which is compatible with talocalcaneal extra-articular impingement. This is a patient with now calcaneofibular impingement. The calcaneus is in so much hindfoot valgus that is impinging on the fibula. Notice that the marker is lateral right here. The marker is lateral, compatible with pain along the lateral aspect of that foot. Moving on to the peroneal tendons. The peroneal tendons are held in position posterior to the retromalleolar groove and held in position by the superior peroneal retinaculum. We see them descending nicely down here on sagittal images. The peroneus brevis is anterolateral to the peroneus longus, and we look at this spectrum of disease again. When we have peroneal tendon pathology, we need to ask multiple questions. So we need to say what kind of tear is it. In the brevis, we usually get longitudinal split tears. In the longus, we usually get partial or complete rupture. Is it traumatic versus inflammatory? Both the peroneal tendons as well as the posterior tibial tendon are often associated with inflammatory rheumatological disorders such as rheumatoid arthritis. Peroneal tendons are often injured in association with inversion injury. So we want to look at the lateral collateral ligaments and the syndesmotic ligaments. We want to see other findings such as osteochondral lesions that may be associated with the peroneal tendon pathology. If we have dislocation, we want to look at the shape of the retromalleolar groove, and we look at the superior peroneal retinaculum. If we have a peroneus longus tendon abnormality, we want to see the peroneal tubercle, and I'll talk about that. And I won't have time to talk about the asperonium, but we also want to evaluate that. So let's look at examples. This is a 33-year-old woman, and we see that the peroneus brevis is split into two pieces. There is increased signal within it. There is also tenosynovitis. This is a different patient where the tear is more distal. Most of the time, peroneus brevis tears are in the retromalleolar groove area, but they can extend more distally, as we see here, two limbs of that peroneus brevis with increased signal as well as marked tenosynovitis. We could appreciate it better on the sagittal images. This is a patient with peroneus longus tendon tear. Peroneus longus tendon tears usually occur more distally, either along the lateral wall of the calcaneus or underneath the cuboid. We see here a complete tear of the peroneus longus, and remember I said you can have friction-related marrow edema or inflammation, and we see here lateral calcaneal marrow edema. Now, this is the peroneus brevis here, and this is peroneus longus. Keep in mind that when you see peroneus longus pathology, you may have an enlarged peroneal tubercle. And this is a coronal image, big peroneal tubercle. You could see displacing the longus in particular. And this is another patient with very big peroneal tubercle, which is actually confluent with the retrotrochlea eminence, and we could see that the peroneus longus is markedly enlarged. The peroneal tubercle separates the peroneus brevis from the longus. When it is hypertrophied, it can cause quite a lot of pain. It is found in about 40% of patients, but it's not always hypertrophied. Here we have a patient with a big peroneal tubercle laterally displacing the peroneus longus. Notice where the marker is indicating patient's pain, and we have a large amount of tenosynovitis surrounding the tendons. Now moving on to the superior peroneal retinaculum, it is a fine low signal structure holding these tendons in place posterior to the distal fibula. This is a patient with stripped superior peroneal retinaculum and dislocation of the peroneal tendons. This is another patient with stripped off superior peroneal retinaculum. In this particular case, the peroneus brevis is torn. There's a piece here and a piece here that is dislocated. This is another patient with marked tearing of the peroneus brevis due to dislocation and stripping of superior peroneal retinaculum. Notice, by the way, that this posterior aspect, that the retromalleolar groove is markedly irregular, it's flattened, it's flared laterally. This predisposes to the superior peroneal retinacular injury and to the dislocation of the peroneal tendons. Keep that in mind and make mention of it because the surgeon wants to know that. Finally, I'm going to talk about Achilles tendon tear. The Achilles tendon is a strong tendon, very commonly injured. We could see it as either a tear or tendinosis. When you see a tendon tear, think about it. Is it in the mid-substance or is it an insertional tear? What is the size of the gap? What is the status of the opposing bony tendon fragments? If you have insertional tendinosis, do you have a Haglund deformity associated with it? And finally, when you see abnormal tendon, do you have underlying familial hypercholesterolemia and xanthomatous changes? The Achilles tendon should be equal in girth throughout its course and should have a flat or concave anterior surface. This is a patient with Achilles tendinosis. We see fusiform thickening of the tendon. We see that the anterior surface is now convex instead of being concave or flat. We're also seeing a little bit of fluid within the retrocalcaneal bursa. That's not something to worry about. It's too little. Compare it to this person. This patient also have fusiform tendinosis, but now has increased signal. So there may be superimposed longitudinal splits. There is edema in Kagas fat pad, reflecting peritendinosis. There's also marked distension of that retrocalcaneal bursa. A little bit of marrow edema here. Compare it to this person, insertional tendinosis, probably partial tearing right here, distended retrocalcaneal bursa, and erosion here with marrow edema. When you see a pattern like that, think about superimposed inflammatory process, such as in this patient with rheumatoid arthritis. Insertional tendinosis should be or may be associated with ossification and with a Haglund deformity. Comment whether you have prominence of the superior aspect of the calcaneal tuberosity. Finally, tearing. Usually partial tear starts posteriorly. You could see that it is superimposed over tendinosis, and we could see the tear right here. Here we have a complete tendon tear. When you see a complete tendon tear, you need to see the size of the gap, as we see here. You need to say something about the status of the opposing soft tissue tendon fragments. And finally, when you have thickening of a tendon and you're thinking about tendinosis, ask yourself about the differential diagnosis. Most of the time it's going to be tendinosis, but it could also be heel tear. It could be postoperative repair of a tendon tear, or most importantly, it could be xanthomas. Not that common, but does happen, and you need to recognize it. So, for example, here we have a thickened tendon, right? You would think fusiform thickening, probably tendinosis, but this patient actually had a complete or high-grade rupture 2 months before that, and now is healing with this thickened tendon. And this patient actually had xanthomas, bilateral xanthomas, as we can see them here. This is a markedly thickened tendon, bilateral. You can kind of see the xanthomas. That's how you distinguish this from tendinosis, chicken wire type of appearance of the low signal. So finally, in summary, I've talked about traumatic, degenerative versus inflammatory changes in a tendon. Keep in mind, you can even have deposition disease. We talked about the posterior tibial tendon. Look for spring ligament pathology, sinus tarsi syndrome, and extra-articular impingement. When you're looking at the peroneals, look at sequela of inversion injuries. For example, with the PERONEUS BREVIS, you want to make a statement about the fibular groove. If you see dislocation, you want to make a statement about the superior peroneal retinaculum. With the PERONEUS LONGUS injury, very commonly you have hypertrophied peroneal tubercle. And with the Achilles tendon, look at the gap, measure the gap, look at the opposing tendon fibers, look at Haglund deformity with insertional tendinosis, and make sure you're not missing xanthomas. Thank you very much.